Hello, am I audible?
Yes, sir, you are audible.
Good evening, Dr. Mukesh. How are you?
We are going live
Hello,
in next
Mukesh.
10 seconds. Sir.
Good,
Hello,
Mukesh,
good evening, Dr. Rohit.
So, how are you?
I'm fine,
Long
fine.
see, after so many years.
Yes, yes.
15 साल तो हो गए होंगे, बीच में हालांकि मिल रही है अपन मीट में.
हाँ, सही में, सही में.
Good, good. और डॉक्टर शिवांग जी ने ज्वाइन कर लिया क्या?
अभी तक तो नहीं.
अच्छा, अच्छा, अच्छा.
So it's already 7. Can we go live?
Yes.
Yeah. We are going live in 5, 4, 3, 2, 1. So we are live now.
Good evening, everyone. I would like to invite Dr. Rohit Swami, sir. He is a consultant medical oncologist, Narayana Multi-Speciality Hospital, Jaipur. Sir, kindly proceed.
Yeah. So, good evening, everyone. I am Dr. Rohit Swami, and today we are here to discuss about metastatic colorectal carcinoma. And we have, hi, Dr. Shivang. Good evening. How are you? Hello. So we are going to discuss about metastatic colorectal carcinoma, and we have a very good panel of consultants who are going to discuss about metastatic colorectal carcinoma. And thing about metastatic colorectal carcinoma is that this is basically a disease of elderlies, but also occur in few syndromes in young patients also, and if treated very properly, then the overall survival or median survival can go up to 4 to 5 years only. The thing which is most important in it is sequencing of treatment, what has to be used in first line, what has to be used in second line, and definitely then surgical aspect is also very important, whether oligometastatic disease, what is the definition of oligometastatic disease, how it should be treated, and what is the cure rates, and when we should go for curative intent and when we should go for palliative intent, and these part will be covered in this symposium. So we have very learned faculty here today with us. So our first speaker is Dr. Mukesh Mandavaria. Dr. Mukesh Mandavaria is senior pulmonologist in Railway Hospital, Jaipur, and he is going to discuss about incidence, symptoms, and causes of colorectal carcinoma. He had done his MBBS from SMS Medical College and has done his MD also from SMS Medical College. And our second speaker is Dr. Shivang Mathur, who is senior specialist surgeon in Railway Hospital. And he is going to discuss about surgical aspects in metastatic colorectal carcinoma. And he has done his MBBS from reputed Chennai Medical College and has done his MD from SMS Medical College, MS from SMS Medical College itself. So welcome all, welcome Dr. Mukesh and welcome Dr. Shivang. And let's start this discussion, and we'll start with Dr. Mukesh Mandavaria, who is going to discuss about incidence, symptom, and causes of metastatic CRC. So up to dice is to you, Dr. Mukesh. Please take over.
Okay. Thank you, Dr. Rohit. Good evening, everyone.
Good evening.
I'm sharing my screen.
Yeah.
Yes, today we will discuss about colorectal cancer, and I will give you just overview of colorectal cancer. Colorectal cancer is the cancer that begins in the cecum, colon, or rectum. If you talk about incidence of colorectal cancer, it is the third most common cancer worldwide. The left box is showing a global scenario. Out of 19.3 million new cases, around 2 million cases, new cases were reported in 2020 globally, and this is the 10% of among all. And the right box showing Indian scenario, around 65,000 cases were reported in 2020. And this is the statistics of Tata Memorial Hospital, Mumbai. In 1996, around 25,000 cases were reported, but in 2020, the number increases up to 80,000. The causes of colorectal cancer: uncontrolled abnormal cell growth, which starts in the colon or rectum, form a mass of tissue which is known as polyp. This polyp usually begins as a non-cancerous, but over a time, around 10 to 15 years, it becomes a cancerous tumor. And these are the various polyps. There is some mutations are responsible for colorectal cancer, and these are the inherited mutations, acquired mutations, and some conditions and syndromes are associated with colorectal cancers, like familial adenomatous polyposis, Lynch syndrome, Peutz-Jeghers syndrome. There are various risk factors of colorectal cancers. These are age older than 50. The previous family history of colorectal cancer, especially first degree relatives, high animal fat diet or low fiber diet, sedentary lifestyle, smoking cigarette, and excessive alcohol consumption. If we talk about symptoms of colorectal cancer, the early stage of colorectal cancer may have no signs or symptoms, but in advanced stage, they may include the blood in stool, the change in stool of the change of shape of stool, for example, pencil-like or ribbon-like stool due to narrowing of bowel or large intestine, and abdominal cramping and discomfort, and constant feeling that bowel doesn't empty completely, and prolonged constipation or diarrhea, and some congenital symptoms are there, the decrease in appetite and unintended weight loss. The various stages of colorectal cancer. The stage 0 means the cancer is only in the innermost lining of the colon or rectum. The stage 1 is the cancer has not spread beyond the inner wall of the colon or rectum. Stage 2, the cancer has spread into the muscle layer of the colon. Or stage 3, cancer has spread to regional lymph nodes. And stage 4 is cancer has spread to other parts and metastasis has taken place already. If the survival rates depends on the disease spread. If disease remains localized or confined to primary site, the five-year survival rate is around 90%. But if the disease spreads to regional lymph node, the 5-year survival rate is comes to around 70%. And if metastatic taken place, it comes to 12.9%. There is screening for colorectal cancer is very important, because colorectal cancer is preventable, and by screening we can detect at early stage, and early diagnosis means a better chances at successful treatment. There are various screening modalities like stool based or visual screening. A high sensitivity focal occult blood testing is non-invasive but less effective. It needs to be done more frequently, and the visual screening is like flexible sigmoidoscopy, colonoscopy, and CT colonography. Colonoscopy is the gold standard in terms of screening of colorectal cancers. We can prevent the colorectal cancers by doing exercises, increase fiber diet or decrease animal fat diet, decrease or avoid the red meat, and avoid smoking or excessive alcohol consumption. There are treatment options for primary and metastatic colorectal cancers like surgical medical or radiotherapy, and this part is will be discussed by next speaker, Dr. Shivang Mathur from Radio Hospital. Thank you. Over to Dr. Rohit.
Such a lovely talk covering all the incidents, symptoms. We learned a lot of things for relate on the surgical one. Your mic is off. Your mic is off, Dr. Shivank.
Yes. Thank you. Hello, good evening, everybody.
Yeah.
Am I audible?
Yes, sir.
Yeah, you are audible.
Okay, thank you. Good evening, everybody. I am Dr. Shivang Mathur, and in the next few minutes, I'll be talking about the surgical management of colorectal cancer. Please share the slides. Yeah, thank you, ma'am. Yeah. So, as rightly said by Dr. Mukesh, that colorectal cancer incidence has been increasing day by day, as also mentioned in the Tata study. But a good thing about the colorectal cancer is even in the metastatic stage, it is curable and it has got a very good 5-year survival. So, like in all cancers, like in all cancers, there is a multimodality approach in colorectal cancers. In a multimodality approach, including the surgery, chemotherapies, and the radiations. So similarly, in this colorectal also, we have a multimodality. And out of that, surgical management has got a special significance, because even in a metastatic disease, you can very well treat the patient and reduce the morbidity and prolong the longevity of the patient. So what are the primary objectives of the colorectal cancer surgery? Of course, the most important primary objective is you have to remove the cancer itself. And also by removing the cancer, you are able to prevent the surgical morbidities or the mortalities, like the stricture, the perforations, and other disseminations. And apart from that, removing the cancers, you have to take care of do the total mesorectal excision, which includes removal of the feeding vessel at the origin and the mesentery, along with the lymphatics and the adjacent organs with direct tumor involvement. Now, what is actually an optimal oncological clearance? It has been very well said that there should be a number of lymph nodes, which we can say that it is the amount of lymph nodes which are resected, which can lead to a good surgical clearance and lead to a good staging, which can help in good staging. So what they have observed is like more than 12 number of lymph nodes is considered as an optimal oncological clearance. Prevention of local recurrence, as we all know, apart from radial margins, it is also important that the total mesorectal excision is very important, and it is the circumferential resected margin which has got a very good significance in the prevention of the risk factor, increase in the recurrence. Apart from that, one of the objectives is improving the quality of the life of the patient. Next slide, please. So what are the basic surgical approaches to deal with colorectal cancer? The most important is the wedge resection. There is a segmentectomy, which also can be considered as a colectomies. Lobectomy in case of liver involvement or lung involvement. And the approach can be both in a simultaneously or a staged procedure in case of a synchronous or a metachronous lesion. And of course, multiple resections are also being done. Next slide, please. So you can see in this diagram, there are various types of hemicolectomies and the colectomies. You can see very well that there are various surgical procedures like the right hemicolectomy, extended right hemicolectomy, where you resect the hepatic flexure, the transverse colectomy, where you remove both the hepatic and the splenic flexure, the left hemicolectomy is in cancers involving the descending colon, sigmoid colectomy, anterior resection, low anterior resection, APR, subtotal colectomies, and sometimes you require a total colectomy to be done. Next slide, please. Now, what should be the surgical resection of the primary colon cancer? It has been said that proximal and the distal resected margins should be more than or 5 centimeters. And for patients undergoing right hemicolectomy, the length of ileum resected does not influence the local recurrence. Basically, the suspected radial margins either pre or intraoperatively should undergo extended surgery, including en bloc resection of the adjacent organs. Along with that, circumferential resected margins has also got a very good important significance because it helps in prevention of recurrences. So there is a role of a total mesorectal excision where you excise the whole tumor along with the feeding vessel right from the origin of the feeding vessel, so you can get a good lymphatic clearance. Now, who are the candidates of resection? Basically, in colorectal cancers, almost in every stage of the patient requires a surgical resection. There are basically primarily two contraindications of a surgical resection. First is a disseminated disease where you cannot do a surgical resection. The disease is unresectable. And second is the poor general condition of the patient who cannot tolerate such a major surgery. What are the general principles or goals of resection? Is the removal of, I have already explained, it is the removal of tumor, vascular pedicles, and the lymphatic drainage. Next slide, please. Now, based on the latest NCCN guidelines, if you'll talk about the resectable non-metastatic colon cancer, of course, you need to do a workup, which Dr. Mukesh has already said. Apart from that, you may have the following findings. Suppose if the cancer is resectable and it is non-obstructive, then there is no doubt you have to do a colectomy, transmesorectal excision with en bloc removal of lesional lymph nodes. If the tumor is resectable and obstructing, then the modality of treatment changes because it may vary, because you can do a single stage colectomy with en bloc resection, which is a definitive procedure, or you can do a resection with a diversion, and later on you can convert into an en bloc resection, or you can put a stent or a diversion and do an en bloc resection in the second stage. If the patient is having a bulky nodal disease or a clinical T4B lesion involving the adjacent organ, there is a role of a FOLFOX or a neoadjuvant chemotherapy, which helps in shrinking and cytoreduction of the tumor. And in the later stage, you can, after 2 to 3 months of the chemotherapy, you can plan for a radical resection. In the locally unresectable or a medically inoperable cases, there are various approaches. Best is to give the supportive care to the patient. Along with that, there is a short-term radiation therapies with 5-FU infusion, which is also found to be fruitful. Next slide, please. Now, we'll talk about the different stages of colorectal cancers and their treatments. Stage 0 means it is an in situ carcinoma, and it is a localized carcinoma. It is basically a polyp, a pedunculated or a sessile polyp, where we can do a polypectomy, colonoscopic. The things which we have to ensure is that the margins which are being taken while doing polypectomy should not have any positive margins or the signs of dysplasia. In that case, we have to do a segmental resection even in a stage 0. Stage 1 is a tumor which is having which has gone deeper through the colon wall, but has not spread. It is up to the muscularis propria, and you have to do a surgical resection in these patients. Stage 2 is the patients with all kinds of localized colonic cancers, and there is a role of adjuvant chemotherapy in such patients apart from doing the radical resection. Stage 3 is patients with lymphovascular invasion, and in these patients, the adjuvant chemotherapy is mandatory, and you have to do a surgical resection. It depends whether you want to give the patient a neoadjuvant chemotherapy or not based on the high risk factors. Stage 4 is the metastatic stage, and it depends whether it is an oligometastatic disease or a resectable metastasis. If it is a resectable metastasis, like a single lobe of liver is involved, then you can do a resection of the colon along with the resection of the affected part in a single stage or in a 2-stage step, along with combination chemotherapies plus minus radiation therapy if required for symptomatic relief to the patient. Next slide, please. Now, as we have already discussed, stage 1 cancers have got a very good survival rate. and it is almost up to 90% of the survival rate. Patients with T2 tumor, lymphovascular invasion, low rectal lesions, poorly differentiated cancers, and male sex are associated with a higher risk of recurrence. In stage 1, basically there is no adjuvant chemotherapy which has been shown to be beneficial, and there is no surveillance schedule has been shown to be beneficial in stage 1 cancer. Next slide. Now, what is the neoadjuvant role in treatment of stage 2 and stage 3? Stage 2 and stage 3, by that I mean both localized disease and disease with lymphovascular invasion. Patients with low risk, who have no evidence of extramural vascular invasion and whose the circumferential resected margins are negative, you can very well go for a total mesorectal excision. But patients with intermediate and high risk, patient has to be counseled about the benefits, about the pros and cons of surgery versus the chemotherapies, versus the total neoadjuvant chemotherapies, and based on the patient consents and based on those the treatment option changes. If patient give consents for chemotherapies, then patient should be put on neoadjuvant chemotherapy followed by the total mesorectal excision. And if patient does not give consent, then we can go for a total mesorectal excision. Patient explaining to the patient that the treatment prognosis may change. Next slide, please. Now, there is a European state European society which gives a guidelines for the treatment algorithm of patients with advanced or metastatic cancer. Even in patients with advanced or metastatic cancer, if the patient is found to be fit, our goal should be primarily to resect the disease followed by adjuvant radiations. But if the patient is unfit, the best modality is the supportive care. If the patient is unfit but having an oligometastatic disease, and then we can also plan and we can do a molecular profile staging followed by cytoreduction and disease control, which includes the first line and the second line chemotherapies, which Dr. Rohit will be explaining in a much detailed way. Next slide. Now, in a liver limited or a dominant disease, because we have found there are many synchronous or metachronous lesions associated with colorectal cancers, and if the liver metastasis is resectable, we should always do a surgical resection of the liver segment, and apart from the segmental colectomy. But if it is borderline resectable, then the question arises whether we should start the patient on adjuvant chemotherapies. And if it is not resectable, definitely the answer is chemotherapy followed by surgery. Next slide, please. Now, there are technical criteria for liver resections, and there has been a paradigm shift in the approaches how to deal with these liver metastasis. The new concept is based on what remains. Like the principle should be an R0 resection, and we should have an adequate remnant liver. By R0 resection is of both intra and extrahepatic disease must be feasible, and it has to be at least 2 adjacent liver segments which needs to be spared. The vascular inflow, outflow, biliary drainage must be preserved, of course, and the volume of liver remaining after the resection must be adequate, at least 20% of the total estimated liver volume for normal parenchyma, and 30 to 60% if the liver is injured by chemo or if the patient is cirrhotic. Next slide. So if patient is having a bilobar disease, so you can plan a 1-stage hepatectomy or a 2-stage hepatectomy. In 1-stage hepatectomy, if patient is having an adequate liver volume, we can do a 1-stage hepatectomy. In 2-stage, again, the first stage, we will do a wedge resection of the lobe or segment 2 or 3 resection. And then we will do a right portal vein embolization. We'll wait for 6 weeks to allow for hypertrophy and continue chemotherapies. And after the portal vein embolization, we plan for a 2nd-stage hepatectomy. So there is a role of embolization, endovascular management also in patients with colorectal cancer. Next slide. So what about the metastatic colorectal cancer? What is the scope of problem? As Dr. Mukesh has already said, that has been a serious problem in our Indian society. And out of these 30 to 35 patients with liver only metastasis, 10 to 25% patients are only the candidates of surgery. And in those patients, we aim to undergo an R0 resection, because R0 resection has got a very good cure rate and a very good 5-year survival. As mentioned here, it is approximately 30 to 70%. Whereas in patients who are not the candidate for surgery, the best therapy is a palliative therapy, where R0 resection is not possible. Next slide. So what is the influence of resection on survival? The colorectal cancer, in spite of the rising trend, has got a very good 5-year survival compared to other cancers. In resectable resection, when resection is performed, it has got a approximately 51 months of 51 months of survival. And in non-resected, it drops down to 30.8%, and in unresectable, it is 18 months of survival. So you can very well see that if a colorectal cancer patient comes to you and we manage it as per the protocols, then it has got a very good survival rate. So we should always follow the multidisciplinary approach in colorectal cancers. And our primary objective is to achieve a good 5-year survival in these patients. Thank you. Hello? Next slide. Thank you. Thank you, sir. This is all about the colorectal cancer. So the take-home message, what I can say is, like, there is a very good significant role of surgical resection, even in patients with metastasis, unlike other cancers. And we should always have a multidisciplinary approach. And with the recent advances, I think the prognosis and the survival is going to improve in colorectal cancer. Thank you, Dr. Rohit, and back to you, please.
Thank you, Dr. Shivang. That was a very nice talk covering resectable as well as oligometastatic diseases. Also, you enlightened us about the treatment of when to give neoadjuvant, about the treatment of in the curative setting as well as in metastatic setting. So I have one query. If a patient come to us with a say large sigmoid colon mass, and
Yes,
there
sir.
are 2 liver mets which are upfront resectable, and definitely there will be regional lymph nodes. So what is our usual approach? Do we go for neoadjuvant chemotherapy, or if it is surgically resectable, we go for upfront surgical resection, R0 resection followed by adjuvant chemotherapy in your
Sir,
practice?
there is definitely a role of adjuvant chemotherapy in these patients, sir. But in a specialized center, if you can do justice with the liver resection and you can achieve an R0 resection, both in case of liver resections and in case of the primary tumor, then I think resection of the surgical part may increase the prognosis survival, but definitely patient has to be counseled, because sometimes patient what says ki sir, since the disease has spread to many organs, so we should do a debulking first and then so
Yeah,
this is the
yeah.
practical thing. This is the practical thing which we faces often because
Yeah,
patients are also educated like this.
yeah, I agree with you, and I think the survival is same. If you go for upfront R0 resection followed by chemotherapy, or you do neoadjuvant surgery, then adjuvant chemotherapy.
Yes, sir.
So that was a very nice talk.
Yes, sir. Thank you, sir.
So next talk is mine only, and I'll be sharing my screen. I'll be discussing about the management of metastatic colorectal carcinoma in present scenario. What are the various treatment modalities available to us, and what should be our sequencing of therapy. So, as we have known that only chemotherapy has given us median survival of around 15 months, and as we developed these chemotherapies like from infusional 5FU and leucovorin, we went to fulvestrant increased to 18.6 months, and then oxaliplatin also added in the median survival by 1.5 months. And then we came with the biologic agents, the targeted agents like cetuximab, bevacizumab, with further increases survival of colon metastatic colon carcinoma up to 21.3 median overall survival. And when we tested use of cetuximab in RAS wild type cases, then we find out that these EGFR antibodies, which are panitumumab and cetuximab, they do much better in non-RAS mutated KRAS wild type of metastatic colon carcinoma, reaching up to 33 months of median overall survival in metastatic setting. And when we do expanded RAS, that is KRAS, NRAS, and other RAS mutational analysis, and if these are wild type, then our median overall survival reaches up to 32.5. And if it is left-sided tumor and RAS is wild type, all RAS are wild type, then with cetuximab and chemotherapy as a first line, our median overall survival reaches up to 40 months. So it is all the game of what the mutations are there, and what are the targeted therapy are there, and what is our first line approach, whether we are going for chemotherapy alone or we are giving chemotherapy with targeted agent, and which targeted agent, and when to be given, and how to sequence it. So there are different characteristic of the patient which decides the treatment choices in metastatic CRC. So we can say that it is an individualized treatment. There is a different treatment for each and every metastatic CRC. The patient characteristic which influences our treatment is comorbidity with the patient, age of the patient, prior adjuvant treatment, time of completion of prior adjuvant treatment, his performance status. Tumor characteristic also influences our treatment, like what is the tumor burden, whether there is a resectability or not, what is the tumor location, whether it is left sided or right sided. And then there comes the molecular characteristic also, which also influences our treatment, like what are the mutational status of RAS, BRAF, HER2, MSI. And these mutation analysis also suggest us when to use and what to use. And then the patient preference is always there in the metastatic setting. Our two goals is only to maintain quality of life of the patient and to increase the survival of patient. So therapy has to be tailored according to individual patient's need, and treatment should be individualized in metastatic setting. So which biomarker has to be done, and whether it should be done in the first line only, or in the first line we should give chemotherapy, then we will do biomarker, and then we will add targeted therapy in the second or later lines. So that also depend on tumor location and molecular characteristic, and ideally we should do all these molecular characteristic on the baseline only, and we should add targeted agent with the chemotherapy. And why should we do this? We'll see in the next slides. It increases survival as well as PFS benefit of the patient. So not only NCCN, ESMO as well as ESMO Asia also have the guidelines which says that all these mutational analysis should be done at the baseline. RAS, BRAF, and MSI as well as HER2 status should be done in the baseline. And anti-EGFR agent, which is cetuximab or panitumumab, should be used in the left-sided metastatic CRC, irrespective of our treatment goal, whether it is a tumor burden reduction or whether it is only palliation. So two meta-analyses are there which have shown us that in the left side, RAS wild type metastatic colorectal carcinoma, anti-EGFR antibodies are far much better than VEGF antibodies. So cetuximab and panitumumab are much better than bevacizumab in left-sided wild type metastatic CRC. So first is Kathak meta-analysis, which included 3 phase 3 trial, and it showed significant overall survival in the left-sided wild type RAS wild type colorectal carcinoma, as compared to use of bevacizumab with chemotherapy in first line. Similarly, there is a Lee meta-analysis which had two groups. Actually, there were 3 groups, but the groups of our interest are these two only. So in the group A, survival and PFS was compared between the patient who received first line in the same setting, left-sided metastatic colorectal carcinoma, RAS unmutated. So they received first line EGFR followed by anti-VEGF, and other subset of patient in group A received first VEGF inhibitors followed by EGFR inhibitor, and there was clear-cut survival benefit as well as PFS benefit in the with the use of first line anti-EGFR, which is cetuximab or panitumumab. And in the group B, there was a first line use of VEGF inhibitor bevacizumab in both the groups, in both the subsets. But in the second line, EGFR was used, and in the second line, anti-VEGF was used. So these are wild type left-sided metastatic colorectal carcinoma, and use of cetuximab after use of bevacizumab doesn't give us any PFS or overall survival benefit as compared to continuing bevacizumab in the second line. So it gives us idea that if we are going to use EGFR inhibitor, we should use it in the first line if it is left-sided tumor and it is RAS wild type. So how do we use first line treatment in left-sided wild type RAS? We got idea from these two meta-analysis that it should be a EGFR inhibitor with chemotherapy backbone. So what are the benefits of first line anti-EGFR as compared to anti-VEGF. So there were several meta-analysis as well as several phase 3 trials which have shown us that there is a overall survival benefit as well as PFS benefit when EGFR is used in the first line as compared to when bevacizumab or anti-VEGF is used in the first line along with chemotherapy. And there are multiple pooled analysis as well as meta-analysis which are supporting this, like Holch meta-analysis as well as Arnold pool analysis, all of them showing significant survival benefit with first line cetuximab or panitumumab in the patients who have left-sided colon carcinoma, metastatic and RAS unmutated. And if we see in these studies only, in these phase 3 trials, which are also included in these meta-analysis, Holch meta-analysis and other pooled analysis, so effect of EGFR in these patients is only seen in the patient who have left-sided colon carcinoma with the RAS mutated. In all of these study, right-sided colon carcinoma with RAS non-mutated, there is no survival benefit, there is no PFS benefit as compared to chemotherapy or chemotherapy plus bevacizumab. So first line for left-sided metastatic colorectal carcinoma with unmutated, that is wild type of RAS, is chemotherapy with cetuximab. So so we are going to use this in the first line. We are going to give chemotherapy with EGFR inhibitors, that is cetuximab in the first line. Then what should be our second line approach for these patients? So if we give cetuximab in the first line and patient progresses, and after that we give second line of chemotherapy or same chemotherapy with bevacizumab, then there is a survival benefit as compared to if we give bevacizumab first and cetuximab later. So this is a subset analysis of FIRE 3 in which arm A, which received cetuximab first and bevacizumab in the second line, had a significant overall survival benefit as well as significant PFS benefit as compared to doing reverse, that is giving bevacizumab first in these left-sided wild type RAS patients. So first line cetuximab also give us advantages in the second line bevacizumab based treatment. So giving first line cetuximab is very important in left-sided wild RAS type colon carcinoma. So evidences tells us if there is a left-sided colon carcinoma wild type RAS, then first line cetuximab chemo followed by second line bevacizumab chemotherapy followed by third line therapies like regorafenib or TAS give us a median survival of around 39 months as compared to first line bevacizumab and second line cetuximab and third line 32.6 months, and these are significant survival benefit with using cetuximab in the first line. And in the all RAS type or left-sided or right-sided using bevacizumab with the chemotherapy where there is no option of cetuximab, then median overall survival fall up to 23.9 months only. So it's a what we can say around 17 months of difference. So ESMO guideline also tells us about what, so this is our second line choice. So if we are giving first line cetuximab in left-sided metastatic colorectal carcinoma, RAS wild type, then we are going for bevacizumab in the second line. But what should be our third line choice? So third line choice in the ESMO guidelines also say that if it is a left-sided, RAS is not mutated, then we can again re-challenge these patients with EGFR antibodies with chemotherapy, or we can go for only EGFR monotherapy if patient is not fit for chemotherapy backbone, or we can go for regorafenib or TAS. And in RAS mutated, doesn't have much options. We can go for regorafenib, TAS, or we can again use bevacizumab if we hadn't used it before. So what is rationale of re-challenging with EGFR inhibitors or cetuximab is that that's a Santini hypothesis which said that in the first line when we used cetuximab, then the cells which were sensitive to cetuximab, they responded, they got removed, and progressive disease was because of those cells which were resistant to cetuximab. And in the second line, when we give known cetuximab based treatment, then these cells which are responsive to cetuximab again increases, their population increases. And so in the third line, again cetuximab can be helpful. So there is only one prospective study in the third line of cetuximab, which is phase 2 cricket trial where cetuximab was given with irinotecan, and we can see that even in the third line, overall response rate was around 21.4%. And if we treat these patients with regorafenib or TAS or BSC, response rate is around 1%, 2%. PFS is significantly different, 3.4 with the RAS wild type in the third line with cetuximab as compared to PFS of 2 months or 1.7 months. So median OS is also very great if we use the cetuximab in the third line. So our consensus for the left-sided colon carcinoma with the wild type RAS is that first line chemotherapy backbone with cetuximab, second line chemotherapy backbone with bevacizumab, third line if it is left-sided and RAS unmutated, then re-challenge it with cetuximab and chemotherapy. If patient can handle the chemotherapy or rituximab, if patient can't handle chemotherapy, poor PS, then we can give cetuximab alone. And even cetuximab is not feasible, then we can go for options like regorafenib, TAS, or containing VEGF inhibitor bevacizumab with chemotherapy. So there are other studies also. This is a retrospective analysis of various studies which have shown that as compared to third line cetuximab and RAS and BRAF wild type metastatic CRC patient, uh, cetuximab shows significant PFS as well as overall survival as compared to the patients when treated with regorafenib or TAS. So there is significant survival benefit in this retrospective trial as well as significant PFS benefit with significant p-value. So it confirms the role of left-sided tumor who are RAS and BRAF wild type. The third line should be cetuximab based if it is feasible. So what about the right-sided metastatic colorectal carcinoma? So in the right-sided metastatic colorectal carcinoma, whether RAS is mutated or RAS is not mutated, BRAF is mutated or not mutated, there is no consensus throughout the world that what should be the first line, whether it should be a cetuximab or whether it should be a bevacizumab. So with backbone of chemotherapy. So there are ESMO guidelines and several other guidelines are also, there are no consensus like we can say in ESMO Pan-Asian guideline, in the left-sided we have to go for EGFR inhibitor without any doubt, but in the right-sided RAS wild type, either we can go with bevacizumab or we can go with cetuximab with doublet or triplet chemotherapy. And our goal for the right-sided or left-sided, both kinds of tumor, is to potentially resect the disease, to convert the unresectable disease in resectable, to stop the aggressive disease, rapid reduction of disease burden, rapid reduction of tumor burden. So can doublet chemotherapy with EGFR inhibitors can be given in the right-sided non-metastatic, right-sided metastatic colorectal carcinoma with wild-type RAS and BRAF? So there are few retrospective sub-analysis of few studies which have shown that in the right-sided colon carcinoma with RAS wild type, there is a very good response rate, significantly better response rate of cetuximab as compared to chemotherapy. So in the crystal trial, cetuximab FOLFIRI versus FOLFIRI, there was significant PFS, there was significant overall response rate, but as compared to chemotherapy, there was no PFS benefit, there was no survival benefit, but response rate was good. Similarly, in Taylor, there was a significant response rate. There was PFS benefit also in the Taylor with Folfox cetoxy as compared to Folfox alone, and there was significant overall response rate, but no, and significant PFS in prime trial also. So what these studies tell us that if we are dealing with a disease which is marginally resectable or which can be converted into the resectable disease, and whether it is a right-sided metastatic CRC, but RAS is wild type, then we can use cetuximab with FOLFIRI or FOLFOX backbone because the response rate is very good, because there is a PFS benefit, though there is no survival benefit. So if we have the good response and we have good PFS, then maybe these marginally resectable disease can become resectable in these subgroup of patients. So the same thing is that in this study also, in this slide also, we are discussing the same thing, that cetuximab and folfiri can provide us rapid and profound tumor shrinkage, which can help us to go for resection even in the right-sided metastatic CRC. So when the subset analysis of right-sided metastatic CRC, where RAS was wild type in the phase 3 study FIRE 3, so it was seen that these patients had a early tumor shrinkage who received cetuximab plus folfiri as compared to bevacizumab plus folfiri. So even in the right-sided with RAS wild type, cetuximab folfiri gives us better response rate as compared to bevacizumab folfiri, though there is no survival benefit. There was median depth of response was significantly better, 25.8% as compared to 17% in bevacizumab arm. The partial response with ETS more than 20% was also better in cetuximab arm as compared to bevacizumab. But median or survival was numerically better, but it was not significantly better. So, if right-sided colon carcinoma marginally resectable, RAS wild type, then cetuximab plus folfiri can be used for rapid reduction of disease, for early tumor shrinkage, and to convert unresectable disease into resectable disease. But if it is a metastatic setting, then I will not recommend cetuximab plus folfiri in right-sided tumor because there is no PFS or survival benefit with it. And we have two meta-analysis which has also shown us that there is a good tumor response rate with anti-EGFR, that is cetuximab and chemotherapy, as compared to bevacizumab and chemotherapy even in the right-sided tumor. Uh, the two analyses are Holch meta-analysis and other is the Arnold pooled analysis. But still, there is a significant response rate with cetuximab and chemotherapy backbone, but PFS benefit and survival benefit is lacking. So, coming to oligometastatic disease, that is unresectable liver limited disease. So, what is the role of cetuximab? So, there are several studies, though the number of these studies are very small, but these studies have shown that using cetuximab with chemotherapy backbone has converted the number of patients converted unresectable patients to resectable patient very significantly, which Soma Shekhar and et al. Has shown 63% conversion rate, R0 resection rate with cetuximab and chemotherapy. And bevacizumab studies which are shown, bevacizumab with chemotherapy has shown low resectability, low R0 resection as compared to the cetuximab based therapy. And the reason we had already discussed previously, because there is a significant tumor reduction. There is a rapid tumor reduction with cetuximab even in the right-sided metastatic colon patients. And CELM study, CALIM study has shown that if there is a R0 resection, then there is definitely a survival benefit which is significant as compared to the patient which are not resected. So even in the right-sided metastatic colon carcinoma with oligometastatic disease, if RAS is wild type, BRAF is wild type, we should go for chemotherapy with cetuximab with the idea of going for R0 resection later on. So, what is a RAS and BRAF mutation? What is the impact of BRAF mutation on RAS wild type directed therapy? So, around 8 to 15% of the patients are BRAF mutated in colorectal carcinoma. And the thing is that if we go for BRAF inhibition, then these cases progresses through EGFR pathway. And if we go for EGFR pathway, then these carcinomas progresses through BRAF pathway. So that's why there was an idea that we should go double driver blockage of these metastatic carcinoma. We should go for BRAF inhibitor as well as we should go for EGFR inhibitor. So in the second line and above, it has been planned. And the thing is that in the first line, we are going with chemotherapy with cetuximab or bevacizumab only. And when there is progression, then we should go for BRAF plus EGFR inhibitors to block both the driver mutations. So there are few drugs which are approved. Some are BRAF inhibitors, and we are well known with cetuximab, panitumumab, which are EGFR inhibitors. So the regimens which are approved are dabrafenib, trametinib with cetuximab or pani, or vemurafenib plus irinotecan with cetuximab or panitumumab, or encorafenib with biminitinib with cetuximab or panitumumab. So these are approved regimen for these study, and the Beacon study was a study which brought encorafenib plus cetuximab plus minus binimetinib for BRAF metastatic colorectal carcinoma. So metastatic colorectal carcinoma who were BRAF mutated, who were progressed on first line of either FOLFIRI or FOLFOX, that is oxaliplatin based, or uh, uh, that was oxaliplatin based therapy or irinotecan based therapy. So there were three arms of this study. One was encorafenib with cetuximab, other was encorafenib with cetuximab with binimetinib, and third was uh, choice of investigator, whether it is sulfacetuximab or bevacizumab based therapy, and majority were cetuximab based therapy. So arm one was encorafenib and binimetinib and cetuximab. So two blockers, one BRAF inhibitor, one MET inhibitor, and one EGFR inhibitor was in the arm one. And in the arm two, only encorafenib and cetuximab were used. And in the arm three, investigator choice chemotherapy was used. And primary endpoints were overall survival and overall response rate of comparison of first arm with the control or second arm with the control, and secondary endpoint were survival benefit and overall response in arm 2 with control. So there was significant PFS benefit with the triplet, that is arm 1 as compared to control. There was significant overall survival benefit with arm 1 as compared to control. There was significant response rate in the triplet arm as compared to control group. So this showed that in the second line metastatic colorectal carcinoma with BRAF mutation, triplet is much better, at least doublet is much better than EGFR directed therapy only. So in this second line, we should go for BRAF inhibitors with cetuximab, with or without chemotherapy backbone. Similarly, this phase 2 study ENCORE also included the patient who were metastatic colorectal carcinoma progressed on first line of FOLFOX or FOLFIRI, and in the uh, and were and received cetuximab with encorafenib and binimetinib if the response rate was more than 22%. Then in the stage 2, more than 12%. Then in the stage 2, further recruitment was done, and it also showed that there is a significant PFS benefit as well as overall response rate was around 50%. So having an overall response rate of 50% in the second line is very good response rate, and 50% with partial response, and progression was seen in only 10% of these patients. So, and median PFS of this study was around 5 months. So for the BRAF mutated metastatic colorectal carcinoma, we should go for doublet, that is a BRAF inhibitor, encorafenib, a MET inhibitor, a binimetinib, and with that we should go for EGFR inhibitor cetuximab. Now comes that other biomarkers. So other biomarkers are MSI, HER2, and then it comes the CMS. So what is the role of MSI? What is the role of immunotherapy in metastatic colorectal carcinoma? So if MSI is high or MMR is depleted, then in these metastatic carcinoma, we can go for second line pembrolizumab. Now we have the studies which has shown first line pembrolizumab also, and I will discuss that study also. And so we have these three drugs, these three combination, pembrolizumab, nivolumab, and nivolumab with ipilimumab in these patients who have either MSI high or who have MMR depleted. So Keynote 177 was the first study which showed us that pembrolizumab can be used in the first line as compared to chemotherapy plus targeted therapy if MSI is high, if MMR is depleted. So this patient included all the metastatic chemo naive patient, treatment naive patient who has MSI high or MMR depleted, and these were randomized into two groups. One was pembrolizumab every 3 weekly regimen, and other was investigator choice chemotherapy. and primary endpoints were PFS and overall survival. And the study results showed us that there was superiority of pembrolizumab as compared to chemotherapy in PFS. Median PFS was 16.5 months in these patients as compared to 8.2 months, which was with hazard ratio of 0.6, which was significant. And overall survival data were still immature. But the thing was with this study was that on the progression on chemotherapy or investigation choice chemotherapy, the crossover was planned. So most of the patient crossed over to the immunotherapy arm, and when to the immunotherapy arm in the second line, and because of that there was no survival benefit in the initial study. But uh, when this was analyzed by the rank preserving structure failure time model, there was significant overall survival benefit also with the first line pembrolizumab in these patients. So this establishes a new standard. If a patient with a colorectal carcinoma, whether RAS is wild type, BRAF is wild type, but MMR is depleted, MSI is H, then we can go for upfront pembrolizumab as compared to chemotherapy and chemotherapy plus targeted therapy. So we can go for this pembrolizumab with giving very less side effects to the patient, giving survival benefit, giving PFS benefit. And then checkmate 142 showed us that there is a significant response rate with nivolumab and ipilimumab in the first line. Low dose ipilimumab with 1 milligram per kilogram for 4 cycles 3 weekly with nivolumab 3 milligram per kilogram. Endpoint was overall response rate, and there were other endpoints that were overall response rate, blinded review, as well as disease control rate and duration of response, PFS, overall survival. So in this study, overall response rate with nivolumab and ipilimumab was as high as 60% in July, and when it was seen in October, it was around 69% with complete responses of 13. So metastatic CRC with complete response of 13% is a really very good data, very good uh, uh, response what a medical oncologist required. Disease control rate was around 84%, and time to response was around 2 to 3 months. So it takes 2 to 3 months for for immuno plus immuno combination to achieve response, and duration of response was not reached. That is, uh, the duration of response was not reached. So response was still going on. So first line immunotherapy, we have two data which are strong. We can go for pembrolizumab, we can go for nivolumab and ipilimumab if patient is MSI-H or patient is dMMR. Now coming to HER2 status of the patient. So there are several phase 2 studies which has shown us that in the second line or third line, if the patient is HER2 positive, then we can go for combination of HER2 directed therapy like trastuzumab, lapatinib, trastuzumab, pertuzumab, tucatinib with trastuzumab. We can go for TDM1 alone or pertuzumab plus TDM1 or trastuzumab deruxtecan. Sorry. So now we come to CMS classification. So as the science advances, as we have several therapies, we have divided metastatic colorectal carcinoma in consensus molecular subgroups. And these consensus molecular subgroup have their different characteristic and have a different indication of frontline chemotherapy or frontline immunotherapy. And majority of these are CMS S2, which are mainly left-sided lesions and have superior survival after relapse. As we all know, left-sided metastatic colorectal carcinoma or left-sided colorectal carcinoma has better survival as compared to right-sided colorectal carcinoma, whether curable or whether it's a metastatic site. So conclusion, coming to the conclusion, so definitely we should have these biomarkers, these gene analysis, either through NGS or through other ISCs and everything. We should go it on the baseline only. If there is a metastatic colorectal carcinoma, we should go for MSI, RAS, BRAF, HER2, NTRK, and DMMR. So, and we should personalize the therapy as per the individual. Like if a patient is there who is having a heavy burden of disease, who is in the good shape, performance status is good, we can go for chemo plus immunotherapy if MSI is H, for the rapid reduction of his disease. And if a patient is frail, PS2, heavy burden, low burden of disease, and he can't tolerate chemotherapy, but MSI is high, then we can go for immunotherapy alone. So the therapy for metastatic carcinoma of colon should be personalized and should be individualized as per the biomarkers. Thank you, everyone. Thank you for patient listening. Thank you.
Nice talk by Sir Dr. Rohit sir.
Thank you, Dr. Shivan. Thank you.
So we can say that, like, of course, immunotherapy has got now day by day the role is progressing. So we can say that prior to initiation of any therapy, be it surgical or adjuvant or neoadjuvant chemotherapy, we should first do the biomarker study. We should do the molecular staging of the patient of the disease, and then we can decide upon the treatment. That would be best for the patient.
So if the stage is 1 to 3, it is upfront operable, and we don't require any neoadjuvant, then we can go for direct surgery, and after that, on the pathological specimen, we can do all these markers. And generally in this stage 1 to 3, we do not use neither bevacizumab, neither cetuximab, neither immunotherapy. So it is only for the stage 4 patient where we go for these options. And the thing is that if we do NGS, then the report takes around 21 days to come. So at least from the first cycle only, we try to give benefit of either bevacizumab, because cetuximab we can't use till RAS is wild type or BRAF is not mutated. So in the first line, we give chemotherapy with bevacizumab, so there is rapid disease burden, decrease in disease burden. And when these NGS come, then we changes our strategy as per the NGS.
And we do the PD-L1 testing, sir, in metastatic cancer.
Sorry?
In these metastatic cancers, do we do PD-L1 prior to initiation of immunotherapy?
Yeah, definitely no PD-L1. In the colon, we have to go for MSI and DMMR. PD-L1 can be high, but it is not a marker of response in colon.
Normal. Okay.
Yeah. Yes. So initially, till the NGS come, we can't wait. We have to start some kind of therapy so that the disease burden reduces.
Definitely.
So this is our interactive session. Anything from Dr. Mukesh or any audience? I think we have the learned audience also. There are no queries from them. They know everything about metastatic colorectal carcinoma.
Wonderful presentation, Dr. Rohit.
Dr. Siddharth, thank you very much.
और भाई कैसा?
बस भाई, तू सुना क्या हाल चाल?
अब सब बढ़िया.
रायपुर के राजा बने हुए हो आप?
अरे क्या, अब जयपुर के राजा के सामने रायपुर का क्या?
अरे जयपुर में खूब राजा है भैया, रायपुर में एक ही राजा है, सिद्धार्थ तुरकर. So, okay. So, should we conclude the session?
Yes, sir.
Okay, then thank you everyone. Thank you, Dr. Shivang. Thank you, Dr. Mukesh, and thank you all listeners.
Thank you, sir,
for joining this event. Thank you, everyone. Thanks a lot.
Thank you, sir.
Thank you,
Thank you.
Thank you, sir.